Hi, everyone. Welcome to Grand Rounds today. You may have heard the message. It said recording in progress. So that is correct. We are recording today. It will be posted on our website soon after the presentation. So welcome, everyone. Happy Friday. Before we get going here, we've got people logging on, so I'll go over a few of the basics. But our Grand Rounds presentation is presented by the Department of Psychiatry and Behavioral Sciences at the University of Washington. We are sponsored by the Ripley Fund, the department, and the Garvey Institute for Brain Health Solutions. So, a couple things before we introduce today's speaker. We will have a link at the end for a survey. So if you'd like to provide any feedback about our Grand Rounds presentation, stay on afterwards, and when the webinar closes, there will be a link to that survey. We will have another Grand Rounds next Friday, March 14th. Mark Sullivan will be presenting on the 14th. And we may or may not have time for questions at the end today. So we have the Q&A feature activated. If you have any questions that come up during the presentation, go ahead, put those in there, get those queued up. And if we have time, we'll do those before 1 o'clock. We'll see how much time is left. So I think that's everything from me. Again, thank you all for joining us. And now I am going to toss it over to the chair of our department, Dr. Jürgen Unitzer, and Jürgen is going to introduce today's speaker. So I will hand it off to you now.
Okay, thank you. Good afternoon. Welcome to Psychiatry Grand Rounds, everybody. So today I have the great pleasure of introducing our speaker, Dr. Tom Suprono. Tom is one of our own faculty, so many of you know him, and we're really excited to hear from him today. Before I turn it over to Tom, I'm going to share a few things about him that you may or may not know. Tom came to us from California to do his residency and a fellowship with us here at UW a little over 10 years ago. And in addition to his residency training, he has pursued a number of other training opportunities, including a certificate as a master educator from the Academy of Academic Psychiatry, AAP. And since joining our department as a faculty member, he has established himself as a really superb clinician, as a sought-after consultant here at UW and across the state, and is a really great gifted teacher. In fact, Tom's won several of our outstanding teaching awards for his teaching and his mentorship of our trainees. Today, Tom is an assistant professor in our department, is about to be promoted to be an associate professor, and he serves as the psychiatric consultant to the UW Medical Center Transplant team. And on that team, he sees and cares for patients who are being considered for kidney transplants and liver transplants and lung transplants. I think those are the big ones, right, Tom?
Yep.
And in addition to that, he directs our fellowship program in consultation liaison psychiatry. And he's really helped us to grow and to strengthen that program over the last couple of years. But today I've asked him to talk with us about transplant psychiatry and his work in transplant psychiatry. So with that, welcome, Tom.
Thank you, Jürgen. And if anybody didn't see this QR code, go ahead and please scan it now and get registered. We'll be using it throughout the talk. Those of you who have worked with me know that I can't help, but I actually don't like lecturing, and I'd rather have a conversation. So this is my best attempts at doing that in the Grand Rounds. All right, so some of my objectives, really, I'm going to go through some of the history, and that's going to provide some context in transplant. I know that a lot of you have probably very little exposure to transplant, and you're going to ask me to maybe hypothesize about future directions of where transplant's going, and for that reason, I felt like we needed some context here. To do that, we have this map we're going to go over, so we're going to go through the past, into the present, and then eventually the future. And we're going to look through three different lenses: through ethics, the criteria of transplant, and then different models of care. I can't help, because I'm a CL psychiatrist, of thinking about the ways in which we deliver care and how that impacts patient care. I'm going to race really quickly through some of the slides, and the reason is because you don't really need to know this stuff. I just want you to have some foundation and kind of know what the surrounding information is. Otherwise, a lot of the things I'm talking about may not make sense. So, all right, let's dive straight in. As we should always thinking about patients, let's read this case about Betty. She's a 60-year-old Black female with diabetes and alcohol-associated liver disease. Her MELT's 40, and she's kind of ambivalent about pursuing liver transplant because she's worried about taking an organ from other people who might be, quote, like more deserving, people like her own grandchildren who she really cares about. She's sustained now 20 months of sobriety after a 40-year history of drinking. And during that 40 years, though, she roughly had about 15 years where she was raising her children as a single mother and had, quote, no time to drink. But at the same time, she wasn't totally forthcoming in this story. And there was a stint where she was in treatment during the time when she was a single mother. She's found it increasingly difficult to remember to take her medications. So her children who live locally and are obviously adults now, they're really supportive and they make sure her Mediset's filled properly every Sunday. So they're around there to support through this process. She sleeps in 3-hour stints and has kind of no appetite because of ascites. She's starting to have this sense that the world's kind of against her and that specifically the transplant team is trying to figure out a way to deny her because they keep giving her more tasks to do in the pre-transplant evaluation process. All right, so keep that case in mind. We're going to come back to it quite a few times. All right, so diving straight into criteria. It's first helpful to know how short of a time transplants really been around. So since 1954, when the first folks were transplanted to identical twins, and even pretty early on, there was some identification that psychological factors could play a role in how these outcomes, but it wasn't really established and certainly not studied. Thomas Starzl is considered the father of transplant, and pretty early on, recognizing that psychiatric factors were playing a role in transplant, they started to develop some screening measures, but psychiatrists certainly were not involved at this time. And criteria was basically completely exclusionary of mental health illness. So I want you guys to focus primarily on substance use, and that's why I've kind of bolded it here. There's obviously tons of criteria that we could talk about and how that's developed from age. You know, a lot of criteria is created because of the limitations of medical capacity. Early on in the history of transplant, we couldn't transplant people who are 70. Now we can. And as our capacity has improved to transplant, criteria has tried to follow and sometimes lead with different effects, which we'll talk about. So as a whole, in the 70s, basically anybody with substance use was excluded. Specifically people who had like alcoholic-associated liver disease, they were not considered. A far majority of the cases that received liver transplant came from hepatitis C. All right. So then if you look back at Betty and you think about, hey, would Betty have been approved in the 1970s? It's pretty easy to see very quickly that she would not have been approved. One, she had comorbidities. She has a substance use disorder. And then other social components of her being a single mother. And this would be considered like an untraditional form of support. Although this day and age, that's kind of a ludicrous statement. All right, so I want you guys to be thinking about, should this patient be approved during each phase of history? So then moving forward another 20 years to the 1990s, social requirements were still very rigid, but at least they became formalized. They weren't just like willy-nilly, like how the practitioner felt like on that given day. And then substance use started to be considered, but with much longer periods of abstinence required. Mental health or mental illness started to be considered as well, but with very clear exclusions. So people with serious mental illness would certainly be excluded, things like schizophrenia, bipolar disorder, and certainly untreated depression, but more mild forms of depression and anxiety were at least considered on a case-by-case basis. Okay, so then coming back to Betty again, If you think about her in the 1990s, would she have been approved? I think it's pretty easy to see how with only 20 months of sobriety, although in this day and age, we would consider that a very solid win for her, she would probably still not be able to make it. That, and again, social criteria being limiting, and then her history of substance use or failed substance use disorder treatment, which, you know, I hope all of the addiction psychiatrists in here would take issue with that, as I would too. All right, so then moving another 20 years ahead, now we're starting to recognize that, hey, you know, support can come in a lot of different forms. Thank goodness to a lot of progressive movements. And then this is when a lot of, at least the major transplant centers, started to really include psychiatric care and a more psychosocial perspective into both the criteria and care. So we started moving more towards a rehabilitative approach to substance use disorders with short abstinence periods. And now across the country, it's pretty widely accepted that 6 months is the threshold, although from center to center and place to place, criteria varies widely, which is pretty appropriate given that each center has different levels of specialization and focus. And if you made every medical center have the same criteria, there would be actually much worse outcomes because some centers can handle things that other centers cannot. Okay, so coming back to Betty now, I think that in 2010, she probably would have been able to be approved. She'd certainly now be required to see psychiatry to address maybe this disordered sleep, which I'll tell you that this kind of pattern of sleep disturbance for people who with liver disease is very standard and is almost impossible to treat unless it's derived from trauma-related issues. And then same thing with appetite. A lot of these things are medically driven and not necessarily psychiatric in nature. Okay, so now in this day and age and what we're moving towards, but slowly, and it really depends on the center, is more harm reduction models. And you can see, even though I started to highlight more things, because all of these things are starting to be related. So acute alcoholic hepatitis, by nature of this disease, it's acute. So people come into the hospital having like fulminant hepatic failure, and they haven't essentially had a quote chance to be sober for 6 months, and their expected lifespan from there forward, or their prognosis, would be usually in 1 to 2 months. And I hear from my hepatology colleagues that essentially they get calls like this, like at least 5 you know, every 24 hours from centers across the WWAMI region, trying to transfer from ERs and ICUs patients in acute hepatitis and wanting to see if they'll be a transplant candidate. And previous to, like, you know, I don't know, less than 5 years ago, the answer was no across the entire country. So this is the new direction that transplant is moving, thinking about different etiology of diseases that deserve transplant. So, and we'll talk about that a little bit more. Okay, so now take a moment and let's think about, despite this progression in transplant criteria, who is still getting left out, especially from a substance use disorder perspective, from transplant. I'm going to try to switch screens here. This is where things typically go off the rails. So we'll see if you guys had a chance to respond. You can use this QR code if you didn't grab it earlier. And let's see if anybody can put something on there. Refresh this, make sure this is working. Okay, we're just going to call that a fail and move on.
Yeah, so Tom, I was trying, it was asking me to log in and it wasn't letting me.
Oh,
So
yeah,
I
you
don't
have
know
to
if people
log in
might
with
be
your
having.
UW. You have to log in with your UW email, and this is like the software that's provided from UW. Thank you, UW. It's also annoying because you have to log in. I try to work around it, it won't let you. Anyways, it's okay. You get the idea. that no matter where our criteria goes, there's always some amount of the population that gets left out. So we'll have to do like analog version of our participation. So in summary, we're moving from a more rigid exclusionary model of like, we can't transplant a majority of people. And that's, I think largely driven because of the capacity of our transplant surgeons and what was possible from a technological and knowledge standpoint to more inclusive. And, old views of substance use being more moralistic to more treatment oriented, and thinking of obviously substance use disorders as a chronic relapsing remitting illness, and moving away from punitive. So going from not being able to do it at all to long waits to focusing on treatment to mostly focusing on support, accepting that there's going to be ups and downs throughout the disease progression of substance use disorders. Okay. So at our own center, we now do have a separate set of criteria for acute alcoholic associated hepatitis. So I was telling you before that all of our hepatologists get these calls, like quite a number. And if they were to broadly accept every single patient who gets presented to them from various ERs across WWAMI, we would have probably less than 1 in 10 would actually meet criteria to be transplanted in the end. And then we'd have like every single day, like 5+ patients who are not transplantable and gonna die in 2 months, which would be a huge burden, not just from a economic and medical standpoint, but also from a psychological standpoint for our providers, like social workers and nurses who are the front line of treatment for these patients and have to essentially like help shepherd these folks through death specifically at this center. So it would be very overwhelming. But with our 2 sets of criteria, we're essentially trading having a lower threshold for how long you have to prove your sobriety, which is basically moving it to 0, but then having higher expectations in regards to comorbidities like other substance use disorders, psychiatric illness, care support, and other medical comorbidities as well. All right, and we're going to keep coming back to this idea of acute LCHEP. All right, so now we're moving into models of care, and normally I'd switch screens right now and give you an opportunity to think about to answer, and I like to see what other people answer, but we're going to talk about models of care. And so if you think for yourself and just reflect on the fact that what are the models of care where you feel the most effective? And it could be more than one, obviously, So for myself, I might think about like, oh, inpatient consultation, I feel much better and comfortable with than if I were in a more psychotherapy focused setting and so forth. So, okay. So models of care. So in the, we'll just say olden days, and this is a depiction of a lobotomy, psychiatric stability was a means to determine capacity to participate in, like, unfortunately, mostly experimental procedures. So psychiatry, as in most of our history, and actually all of medicine, has somewhat of a dark history when it comes to like why we were necessarily doing things. But I want to always take a more humble approach to this, realizing that like our understanding and what we were capable of at that time was just so much less than it is now. So it's really hard to put yourself in those shoes. So it's easy to get judgmental, not realizing what you thought was possible and what you even knew was the case. All right, so 70s is when psychiatry starts to be a little bit more involved, although there's no specific standardization or specialization, and there's certainly no psychiatrists like involved specifically in transplant centers. Then in order, as always happens in medicine, our medicine colleagues want to start to get us to try to predict what are the patients who are going to have problems in transplant and how can we avoid those? And they don't like, I mean, I always hear like, can you just give me a number as from a scale of 1 to 10 of how likely it is for this person to relapse, or is this person going to, attempt suicide after transplant? And obviously that's an impossible thing to answer, but these are four of the most popular evaluation tools that were developed kind of over time to try to get at some of those things, I think with varying degrees of efforts, but certainly the PsyPat is still used very actively today and maybe one of the most seminal kind of evaluation tools in the transplant world. So when you see a transplant note these days from a social worker, you might often see a PsyPat score. And then just thinking about like when those scores and those evaluative tools were not sufficient, this is when they said, hey, maybe we actually need somebody with a little to be actually involved with some nuance so that they could look at, you know, hey, let's look at these on a case-by-case basis, which is obviously the much better approach, at least from a patient care standpoint, but it does get at like what is most efficient. All right, so just to ground this in time too, this is also around the time when collaborative care was taking roots. And so I kind of already kind of primed the pump here. If we were previously thinking about what's your most like effective form of psychiatric care, you can maybe answer this question in relationship to what is your most efficient form of care. And they might not be the same. And in fact, they probably are not, because all of these models of care fit different needs in different settings. Okay, so looking back to all of my predecessors, this is the lineage of mental health providers at the University of Washington, and you know, they set the stage for me well, and their involvement in transplant has varied quite widely. You're going to hear from Dr. Sullivan next week, not about transplant, but I didn't get a chance to ask him, and I meant to ask him about how involved he was. I heard from social workers that he would do consultation for the transplant team, but wasn't necessarily like at selection meetings or having like, you know, more intimate relationships and liaisoning specifically with the transplant team in the same way that I do. So, okay, we're going to shift gears a little bit because we're going to talk here about transplant and specifically relapse prevention and prediction. So we know there are a number of different ways that we can modulate whether or not somebody may or may not relapse. And you know, these are some of the papers that are working towards predicting who will relapse. So here's the 6 months sobriety that is kind of the threshold right now. And then in regards to this paper, you know, people using the Harrar score to give people like a numeric value to risk of relapse factors, taking into consideration these independent risk factors. And then these risk factors lining up to predict, which is like kind of frightening, this 100% relapse risk, right? And then lastly, pointing out the fact that the gradation of like how long somebody has been sober certainly has an impact on their risk of relapse. And is there a difference between 5 months and 6 months? You know, some, and it is kind of this fairly linear curve, but ultimately there is a difference. And I have to butt heads a little bit with our transplant surgeons from time to time when they say, well, there's no difference between 6 months and 7 months. And, you know, if we continue to extrapolate that, their argument becomes very wrong, as evidenced by this study. But I understand their sentiment, because when it comes to saving a life versus not, 1 month of difference may not actually really make a difference when we're thinking about the severity of the outcomes. Okay, so, and then it's worth mentioning that access to psychiatric care, especially for me across the WWAMI region, has really opened up. Before COVID, I was probably seeing maybe 10% of my patients via tele across, like from Alaska to Montana and so forth. And even for lung, you know, our liver and our lung teams are the only centers for WWAMI plus Oregon. So people have to come really far. So now I would say at least 50% of the patients that I see are still tele. So, and then very recently, 2023, this is when the first practice guidelines came out. So you can see how, these very niche fields of CL psychiatry are a little bit behind the ball in terms of like catching up with developing practice guidelines. But I'm pretty hopeful that these will continue to roll out on a hopefully a yearly sort of basis. But we started with depression here. Okay, so again, now the last kind of piece of the participation puzzle for this section of thinking about models of care. There's what's most effective, there's what's most efficient, and then there's also what we want to do. Because ultimately, even if you had the most perfect, effective, and efficient model, you have to get people to do it. And I know that there are settings for me that are not ideal for my skill set and my personality and the way that I like to work. And so it would not be a long-term plan. So kind of keeping all of those things in perspective. All right, so quick summary here. Basically, there was essentially no to some informal evaluation, and practitioners were not involved or integrated into the system. And as in line with how psychiatric care has progressed throughout kind of in all the fields. You ask Dr. Sullivan in pain or Sam in HIV care, you'll see this similar progression. And hopefully moving more towards these universal guidelines and opening access to care. I'm alluding here to this evaluative process and moving towards predictive, and we'll talk about that in just a minute. So coming back to our specific 2 sets of criteria for acute alcoholic hepatitis, to align with this, it would be ideal if there were specific models of care. And so thankfully, within our own treatment center, we have developed a pre and a post-transplant phase of care. So thinking both preventatively, because sometimes these acute ALK patients do recover. Most of the time they do not, but sometimes they do. And then also, not just like saying, okay, well, we transplanted you, good luck with sobriety, but providing them with very robust monitoring and expectations around engagement with care. And we have an addictions transplant team now, which is really wonderful. And it's largely to kind of address these needs. All right. And then, so I wanted to introduce in Michigan, Winder and colleagues developed this model of providing, I would call it actually proactive care more than predictive care, or supportive care. So this is hopefully before people even need a transplant, when they have liver illness. This is what their morning schedule would look like. So, the hepatologist sees 3 patients, as does the social worker, and as does the psychiatrist. But most importantly, this brief team discussion between each patient. I mean, it's really hard to imagine this. I think you could see between all, 3 practitioners have to be very in step with each other and have very good relationships. But you could see how the level of care could really enhance patient outcomes, and potentially with this more multidisciplinary approach, hopefully avoid and prevent transplant when there's early warning signs of liver failure. So coming back to Betty, thinking about, hey, one, her MELD is 40, so she probably isn't coming back. But let's say her MELD had been, 10, and she had gotten into a clinic like Dr. Winder's, how that may have been preventable with the appropriate incorporation of various individuals in a more seamless form, because oftentimes they'll be seen by the hepatologist, but they don't actually, because of mental health bias and various other reasons, they don't bridge into other forms of care that are especially supportive in providing this long-term sobriety necessary to help avoid that pathway towards ongoing substance use. Okay. Lastly, ethics. So, so there have been epidemiologic shifts that I've alluded to already. So early on, more than 80% of liver cases were due to Hep C. This is for 2 reasons. One, Hep C was much more prevalent than alcohol associated liver disease. But also because of the bias that was embedded into medical culture, our culture as a whole, and how we thought about substance use disorders. But over time, one, because technological advances in medicine, right? So Hep C is kind of like cured. There's numbers of treatment with them. Now there's all of these, theoretically available livers. So where do they go? Well, there's now an epidemic of growing need for alcohol-associated liver disease and patients who suffer from this. But the bias still remains of thinking about alcohol use disorder as a, quote, behavioral illness. And so if you ask a parent whose child has, let's say Wilson's disease and is over at Seattle Children's, and they're competing with a liver with somebody who has alcohol-associated liver disease, this is where you can see how the ethics start to get a little bit more sticky, and people have very strong feelings depending on where they sit in society and their own experience. So whereas before we were trying to essentially how do we make sure we don't kill these patients who need transplants? And as we get better and more capable, we move more from an ethical perspective of let's not hurt them, to who having to decide who gets a transplant. And we know that our criteria is limited by what we are capable of, but what is often not fully accepted or understood, but until more recently, through looking at systemic systems of bias, is these disparities that exist. And so these are well-documented disparities within transplant. And I hope these numbers are fairly appalling to you, the differences in terms of gender, and especially looking at these details of this patient population. And the same thing goes for Black patients and Hispanic patients, which I think, interestingly, Hispanic patients have lower rates of graft failure versus Black patients, both of which are excluded from transplant largely. And I think there's even more environmental reasons to explain some of these disparities. Okay, so this brings us to a real question of, if we're moving away from hepatitis C to alcohol as the primary indication for liver transplants, the question is that where we should be focused? Because there are a lot of other liver diseases. And one reason that we are focusing on alcoholic liver disease is because if you look at these numbers of people with alcohol-associated liver disease and other indications for liver disease, they do super well, which might be surprising to you. And I think it was surprising to the transplant community when this study was done. So, if you're a surgeon and you want to transplant people, you want the best outcomes possible. And the system incentivizes that, as does the actual insurance companies and other nefarious entities. So then the question is, well, if all of these people who are getting transplanted with alcohol-associated liver disease are doing well, does sobriety actually even matter? Well, it turns out it really does. So this is people who don't drink after alcohol-associated liver disease transplants, and this is the people who do. So definitely a very big difference. And then even more disturbing is the fact that roughly, and there's tons of studies on this, and nobody lands on one number, obviously, but as a whole, if you average them all together, it's somewhere between 20 and 60. So kind of 40% is where we land in terms of the rate of relapse. So 40% of the people we transplant with alcohol-associated liver disease relapse. And then when they relapse, huge probability of dying here, right? Compared to those who remain sober. So sobriety does matter. But hopefully all of our addictions colleagues are now thinking, but relapse is not all the same, because there are varying degrees of if you ask somebody walking down the street, do you drink? They might say yes, but they might not drink like another person drinks, and their sobriety might not be like another person's sobriety. So people's definition of these vary quite widely. So if they, this 10-year study, looking at the difference between abstinence and then slipping, which is I forget exactly what the threshold was, but it's something like 2 drinks per week or something like that, to going back to their old patterns of use, which typically for people with alcohol-associated liver disease is somewhere around like 10 drinks per day or more, usually more. So then when they look at separating out these like varying degrees of relapse, we get a whole different new picture. So this solid gray line are those that remain sober. And then this dashed line is the people who would turn to their old use. So that explains that previous chart. But then between that, we have quite a few different other ones. So this solid black line is just like kind of all other types of cases of liver disease. And then you can see again, like our people who just slip actually do better than the general population. So, oh, sorry, solid black is all people who resume drinking. That makes more sense. So the dash dotted and then unknown, these people, you know, they actually do really pretty well. And especially even in relationship to other etiologies of liver disease. So not all relapse is the same. And so the real question comes to like, when we are thinking about bringing up both our criteria and then like our models of care and in relationship to the ethics of transplant, we have to make a decision because, you know, even though it might not be like a zero-sum game, it certainly is an infinite game, and we only have some limited resources that need to be allocated in certain ways. So do we put our money on pre-transplant where we want to like really pick the right patients to have the best outcomes, or do we shift our focus to the post-transplant phase, knowing that this is a chronic illness where, you know, 40% of people will relapse, or probably, you know, probably more, and providing them with the support they need to do as best as possible. So thinking about that from a transplant center perspective is one thing, but then I'd encourage you to think about that same question though from a patient perspective. You know, if I was somebody with liver disease, whether it's alcohol associated or not, would the best care be for me is for a doctor, a team, you know, multidisciplinary team to consider like what is my morbidity, mortality, and taking into consideration hopefully quality of life as well, versus thinking about how do we just mitigate risk and support you after the fact, knowing that frankly everybody struggles to some degree, and outside of like, hey, we're not going to be able to wake you up from the operating table, you know, we'll set that as a different section. You know, maybe we should have much lower thresholds, loosen up criteria even more. And I think this is an ethical conundrum that probably will never be resolved, but something we need to consider because it brings up different subjects depending on where you set that threshold and what models of care we provide. All right. Oh, somebody wrote something in the chat. Oh yeah, that's from, okay. Sorry, I was trying to pay attention to that, but obviously failed. If anybody does have questions or things to chat, I will try to pay attention to that. Okay, so coming back to kind of Winder's group at Michigan, and they're trying to be much more. I don't think they worked previously with that model of more integrated hepatology and transplant care. I think they were trying to be supportive and proactive, but the group took a shift towards trying to predict with this shift in movement of focus on acute alcoholic hepatitis to trying to predict, because this is a very, very high risk population of patients. So in an effort to do that, a majority of the transplant community has focused primarily on insight as the primary quote predictor of how patients will do. There's quite a few other papers looking at this, and it seems like this is where the field is focused. And I would love, especially if there's any addiction psychiatrists on in this Zoom call, if they want to put on the chat or put in a question, what their thoughts are about that. My own personal bias is that, you know, you can have all the insight in the world, but if you're in an environment, which many of these patients are, an environment that is just, pun intended, saturated with substance use, the likelihood that you will be able to maintain sobriety is very, very low, especially considering all the social determinants of health. And then, genetic factors, as well as kind of some of the more, I guess, like psychological components that keep people in a pattern of substance use, like codependency, economic codependency, and other things. All right, so coming back to Betty again, looking and thinking about the ethics that are involved. I specifically made this case. I made Betty Black because I think that her her feelings that the, like, quote, world is against her, and that the transplant team is trying to deny her. Although at least here, I do not feel that we're ever trying to deny people. I tell people very often, we're in the business of trying to transplant people. We don't want to deny anybody, but we also don't want you to die because of what we're doing to you. And at the same time, there's without a doubt bias in all of us that definitely influences the process. And you can see when you're sitting in a selection meeting how these unconscious, very subtle biases exist, not just in the system, but also in us, that is a big part of my job to try to highlight and shine some light on to help provide more equitable care. All right, so I thought when Jurgen, thank you, Jurgen, for inviting me to do this talk, proposed this. He wanted me to make some propositions to where the future is going, and I'm always shy about predictions. Actually, I don't know if that's true. It's fun, but I want to take a very humble approach to that because I don't know, like as anybody else would, where this world's going, especially now. And I wanted to name this section Fork in the Road, but I just couldn't bring myself to do it. At any rate, so here is a quote prediction, and I have to admit I did not come up with this, and in fact I asked AI to create some predictions for me, and I think that their predictions, my personal humble take on it, are totally ridiculous, but I wanted to share them because I thought they were amusing and interesting. So, instead of thinking about this AI-powered risk stratification, it's my hope that instead of, and I'm not going to make predictions, what I'm going to do is provide my own hopes and talk about those for a moment. My hope is that we are going to stop trying to predict who's going to do well. I think we need to think about who can we possibly transplant, and take a more humble approach to that. And instead of trying to predict that, we move away from prediction and we try to be proactive, keeping people from needing a transplant by providing appropriate, in this case, in my example, substance use treatment before they get to this place. And then also after the fact, when our systems before have failed, we actually, instead of being reactive, we try to be supportive. And that's my hope in this realm of criteria and the movement towards like predictive models and screening and so forth. So virtual reality therapy, I don't know, sounds nice-ish. But, truthfully, like telepsychiatry, just at least in my own practice, has just continued to grow. It enables me better access to patients, and patients better access to me, especially economically, like flying from Alaska and Montana to Seattle for a visit, is very expensive. But ultimately, these technologies will never supplant human connection, and that is really a core component of, I don't think, just psychiatric care, but like all medical care. And I think actually in many ways we might move more towards like kind of retro styles of care, because I think as evidenced by this talk of trying to incorporate these surveys over internet and stuff, like sometimes it's better to like just learn in person and raise your hand and ask a question. And, and in many ways, these are better models when we get back down to the basics. Similarly, in the world of a psychopharm, are we going to be able to, check everybody's DNA and come up with a perfect medication for them? I kind of doubt it. And even if we did have perfect treatments for substance use disorder and depression and anxiety and so forth, I think the environment that we sit in is prone to problems regardless. Because we know that a huge chunk of our patients aren't even willing to take treatments or engage in them, even though, like as an example, substance use disorder treatments are widely available. Even though it is hard to get in with certain types of treatments, medication assisted treatment is fairly widely available, even from a primary care perspective. It's really, our internal biases and the environmental setting that people are in and our culture that keeps that from happening. Like, why is the other day, somebody who started drinking at 13, why is a 13-year-old drinking and drinking to a degree where the same patient had liver failure at 32? This is an environmental and a cultural problem. This is not a medical problem. And then my favorite, cyborgs, right? So, I think there actually probably will continue to be development and likely in the end will be synthetic organs created. We have dialysis, we have VADs. I don't treat the heart team, Austin Colfrath does, but he'll tell you, we could theoretically make as many VADs as we want. But that does not resolve the situation. And in many ways, it makes the ethical debate even more problematic, and it starts to get at some more core issues of what holds us back from providing truly equitable care and giving everybody a fair shot at transplant. All right, so I think that is it. So I do have time for questions if anybody has them. I kind of talk fast now, I realize.
Yeah, thanks, Tom. So good news, everybody. We do have time for questions. So if you thought of anything, it looks like no one's typed anything in yet, but we'll give people a minute here to get their questions in. So Tom, maybe in the meantime, while we're waiting for some people, well, first of all, I like your slides a lot. I love the motion graphics. So that was very cinematic. So I'm going to use that someday. But I don't know, maybe we could talk a little bit more about AI. I know you didn't like the answers that it generated, but do you see uses for AI in the future going forward with your work?
Totally. I actually really like AI. I think it's such an incredible teaching tool. One of my favorite, actually at ACLP this year, I went to the like a discussion of how AI can be used, and we're in some small groups. We're talking about using AI as means to incorporate into journal club. So you take a journal and you dump it into AI and you say, hey, take the methods, arguably the most challenging component of a paper to understand, and say, rewrite the methods for this paper for a kindergartner to understand, which would be really cool, right? And then you can, AI always asks you a follow-up, is this what you want? And you can say, actually, not a kindergartner, make it at a 6th grade level. And then you could look at that. And then it's actually make it for a high school student. And then you can see the progression and how language can help to inform what are the key components of a subject or a concept, and kind of develop our understanding and learning in a more layered and nuanced way. So I really like the potential educational implications of AI, and I'm really hoping it's going to do our notes for us very soon. And I know that actually lots of centers already have that, so that's what I'm hoping for if you want a prediction.
All right, so let's see. Nothing else yet. So I have a question for you, Tom. So I'm new to the department. Been here for about 7 months, and so honestly, this is the first time I've ever heard about transplant psychiatry. Is today? So so thank you. It's interesting, but it just makes me think. So how did you first get into this? What's kind of your career path that got you interested in this topic?
Yeah. I wish I had this like really great explanation for how I got in here, but like, and I tell my residents in clinic with me all the time, like things just happen and you can't predict them. And I am one who tends to say yes to most things and at least give it a try. So the truth is, Dimitri Davidal, the person in that slide before, who was a transplant psychiatrist before me, moved on to another job, and Jurgen had me come in and talk to him, and he said, Tom, I think you might like this job. And I was like, I probably don't. At the time, I was inpatient CL psychiatrist only. I mean, most people go into CL because they like inpatient, not because they like outpatient. And it felt so niche that I was like, am I going to be seeing the exact same patient like time and time and time and time again? And so that really scared me. I was like, okay, Jurgen, what is the shortest period of time if I say yes that I have to do this? He's like, oh, 6 months. But I love this job. I've been in it now for almost 8 years. And it is the most diverse clinic I've ever practiced in, from like doing like couples therapy-ish or CL couples therapy to like, have these cases of domestic violence, substance use, dementia, intoxication. Like it's the full gamut, and it's been really, really interesting. And I really love my job. And, I have usually about 3 to 4 trainees with me every 6-month block and so forth. And you should ask them, any of you guys who are interested in it, it really is an interesting and dynamic field, and it's really growing. If you go to ACLP, the CL Psychiatry Conference, this like it's like a special interest group is like one of the fastest growing and largest cohorts now. There's usually about 50 of just transplant psychiatrists there, and everybody kind of knows each other. It's a really fun team, and it's a great support system we have.
Yeah, it looks like we do have a question here now, so I'll go ahead and read it out loud because I don't know if everybody can see it online.
And Jed,
Oh.
before you do that,
Yeah.
since Tom called me out about how he got into this, I'm going to make a comment on that. So first
Okay.
of all, I'm very happy to hear that the 6-month gamble worked out. It turned into 8 years. And secondly, I think I was going to ask you, Tom, what you enjoy about this work, but you just answered that question. And then I'll make a comment instead, which is I think that is one of the nice opportunities we have in a big organization like ours. People start somewhere, when after they train with us, and there are lots of opportunities to evolve, to change, to do different things. And there are other things that you do still in your portfolio today. You talked about your transplant work, but I think it was really nice for me to see how you've evolved this work. It's really beautiful. And like I said, I'm glad that 6-month gamble that I offered you looks like it might have paid off. So I'll fade back out, but Jed, you have a question.
Yeah, so we actually have 2 that came in here now. So the first one that got in here was, so Tom, it doesn't seem that the majority of medicine is moving towards supportive models of care. In what ways can a clinician advocate for patients with a supportive standpoint when other clinicians want predictions and more concrete outcomes?
Yeah, that is the age-old question. And Bethany works with me in transplant, so this is a very Bethany knows I'm going to give an unsatisfying answer because there isn't a great one. But I think one, like in our selection meetings, I'm both there but also behind the scenes when I talk to practitioners one-on-one, trying to increase distress tolerance. Because I think that these cases, especially ones that are like very psychosocially active in nature, really get our transplant surgeons like hair up on their necks, and they're really worried because they don't understand. So I think part of it is about education, knowing that like, in the same way, like we ask one of our transplant surgeons, like, give me the percentage that this person is going to do well in transplant from a surgical perspective. They'll be like, well, that's, I think we can transplant them is what they want to say. But that's kind of where it ends. It's like, this is an impossible thing to actually predict. So I think that we actually need to lean more towards leniency in the selection meeting. And then also, I think we need to just shift the amount of efforts, like clinically, like so be more willing to see post-transplant patients. And I think we kind of have to edge out evaluation to some degree. Every patient needs some evaluation because we know that outcomes are better when we kind of mitigate risk and treat them before. But I think we need to know when to call it quits and say, okay, like you are 20% better than when I met you. Let's pick up the rest after your transplant and just say this is okay for now. Which is a hard thing to do. I think it's a little bit ballsy, but I think it's also kind of the right thing to do.
Yeah. Yeah.
Bethany,
Okay, we'll do one more.
better answer than me, so feel free to chat it in, Bethany, if you want.
All right, we'll do one more. This will be the last question. So this person says they're curious about the current state of organ transplant for patients who have significant intellectual disabilities. So they would imagine that in the early years of transplant, that might have been there might have been an eligibility issue like substance use was. So is it an eligibility issue currently?
Yeah, to some degree. Obviously, people with various forms of intellectual disabilities require more support. And it really largely depends on the caregiver and that relationship and the nature of the cognitive disability. Because some people with cognitive disabilities, actually, it doesn't even matter whether it's cognitive disability or just regular people, when they decompensate from various reasons, socially, psychologically, medically, they react in a way that is not conducive to post-transplant care. So if you're somebody who like, when you're really hungry, you're like, I'm not taking my meds anymore. That's not conducive to post-transplant care. And it doesn't matter whether you have a cognitive disability or whatever the thing is. It's like, can we address that and develop and understand and treat like this pattern that we've unearthed? I was just reading about Bethany's comment. Or and so we're mostly evaluating the team. We think of people with intellectual disabilities as like, what is that relationship like, and what is the nature of the disability like creating in this pattern of adherence and participation in care. I think it's also we need to be a little bit humble about transplant. Transplant like quote saves lives, but really it like extends time. And most transplant patients will tell me like, I ended up trading one set of problems for another, and that is definitely true. And we presume in the setting, and it's most of the time true, that the settings, the problems they're trading are worse than the ones they're getting, but that is not always the case. And especially for people who have more limitations from a cognitive and emotional standpoint, we need to really put that into consideration of like, is no longer having to go dialysis, are you willing to trade that for having diabetes, right? Because sometimes with steroid doses and so forth, people end up having diabetes after the fact. And I think for some people, actually, like especially people with intellectual disabilities or like no structured life, like dialysis can be a wonderful thing where they go and they have this cohort of people that they talk to and the nurses take care of them, and that's kind of like their family. And to take that away and make them poke themselves regularly and take medications in really complex way that does not as line as well with a cognitive disability, I think that's a disservice. So really, I mean, the crappy answer is like we really have to kind of like look at them case by case, but I actually don't think cognitive disability is any different than any other illness, and that's at least my approach.
All right, great. Well, I think we'll go ahead and wrap it up there. So thank you once again for being here. And, for someone who says you don't like to lecture, I thought that was a very engaging lecture. So I appreciate it. And folks at home, I think at the beginning I said that our next Grand Rounds will be a week from now, but it's actually 2 weeks from now. So hopefully you'll all join us again then for our next Grand Rounds. Thanks for being here and have a good weekend.